The cases are going to be presented by Dr. Marwa Ahmed. She's a second-year nephrology fellow at Virginia Commonwealth University. She earned her MD from University of Khartoum in Sudan. She had her residency in Texas Tech at the Maria, and she received multiple awards, including a prestigious George Colmar Award by the VA system for recognizing the resident physician who best exemplifies concern and compassion for patients' families, constant support and kindness to colleagues and staff, and commitment to continuous learning and love of family. So she's currently our chief fellow at VCU and interested in all nephrology, including TMA. And our panelists are going to be Dr. Brad Dixon, who is Associate Professor of Pediatrics and Medicine at the University of Colorado, and his clinical interests include complement-mediated kidney diseases like typical HUS and C3 glomerulopathy, and he is investigator in several clinical trials of novel complement-targeted therapies. And the second panelist is Dr. Carla Nester. Dr. Nester is a professor of pediatrics and division director of pediatric nephrology at the University of Iowa, and she's associate director of the Moral, and she also leads a huge translational research program focusing on rare complement-mediated kidney diseases, and her lab has become a hub for bringing new generations of anti-complement therapeutics to rare kidney disease populations. So welcome.
All right, well, thank you everyone for being here. I will be presenting two cases for today, and I will start with case number 1. We have this 48-year-old African-American female presented initially to an outside hospital, complaining of a dry cough and shortness of breath. CT scan of her chest at that time showed diffuse glass opacities. So she was treated for atypical pneumonia / pneumonitis with antibiotics and was discharged home on oral antibiotics and 60 milligrams of prednisone with plans for outpatient taper. Her labs during her hospital stay and discharge were unremarkable. Creatinine was noted to be 1.3. Her CBC was also unremarkable, except maybe for just mild anemia. Otherwise, it looked fine. She gives a past medical history of hypertension, iron deficiency anemia, Raynaud's, remote history of pulmonary embolism, but she was not on anticoagulation at the time of presentation. She also gives a history of 4 uneventful pregnancies. Family history, she also mentioned that a grandfather had some sort of kidney disease, but she was not able to elaborate more on that. 2 weeks later, the patient presents back to the same hospital, complaining of abdominal pain and diarrhea. CT scan of her abdomen showed evidence of enteritis. Her labs, as you can see, are significantly different from 2 weeks ago. She did have an AKI with a creatinine bumping up to a 2. She also had acute anemia and thrombocytopenia. Given these findings, we did run some hematologic and hemolytic markers that came back positive and consistent with microangiopathic hemolytic anemia. So the question here, and it's for the audience to call, what is the most likely cause of the TMA?
Read out the answers, I'm sorry. We have 6 for antiphospholipid, 1 for lupus.
Okay.
7 for antiphospholipid.
Okay. Any other
We have
thoughts?
an ANCA vasculitis. Nobody has said STEC-HUS. Nobody's voting for TTP. So lupus, antiphospholipid, and ANCA. Antiphospholipid's winning.
Okay, that's exactly the same thing that we were thinking of, but interestingly, all of her immunologic workup came back negative. ANA, anti-double-stranded DNA, complement levels, everything looked normal.
And the ADAM-TS13.
And the ADAM-TS13 as well. So she stayed in the hospital for about 2 weeks, managed with IV antibiotics for this enteritis and the AKI, and she had the TMA as well. At the time of discharge, she was clinically stable. Hematologically, her numbers improved, but unfortunately, creatinine, as we can see, continued to decline. So she underwent a kidney biopsy, but when she was discharged, the results were still pending. Since she was doing better clinically and hematologically, it was felt like it's appropriate to send her without waiting for the biopsy results. So next question is, hematologically she improved, but what is the most likely cause of the ongoing kidney injury?
Knowing the immunological parameters, does it change how you guys are going to think about this?
It's a tie.
It says none of the above, antiphospholipid, ANCA, STEC. Everybody's gone away from lupus. Okay, STEC-HUS, ANCA, antiphospholipid is still there, and none of the above.
Okay. So 10 days later is when the patient presented to our emergency department at VCU, complaining about the same GI symptoms. This time her blood pressure was noted to be elevated. CBC was unchanged. Creatinine was also unchanged from when she was discharged, but clearly she was still having some evidence of hemolysis, although the markers were not as high as before. And at that same time, when she came back, kidney biopsy results were finalized.
Yeah. So I'm going to, oops. Yeah, I don't know. Let me pop there and see. Yeah, just very quickly. I mean, I'm sure many of you have actually seen biopsies, but does my mouse show up now on the screen?
Is it on?
Nope.
Is the mouse on?
Yeah, it doesn't. Yeah, here we go. Is it showing up on the screen for you guys? No? Okay. Well, sorry.
I'll just use my finger.
Yeah. Yes, totally fine.
Old-fashioned
Go for
pointer.
it.
What I really want to show you, first of all, obviously, is what the arrows show, is these nice pink areas. So there is definitely fibrin microthrombi showing up in the biopsy. So that's fairly classic of a thrombotic microangiopathy. So you can see that actually in both of those glomeruli. As has already been mentioned here previously, you can also see in chronic settings, you can see the split basement membrane. So the microangiopathic disease, if you will cause the membranoproliferative pattern for some of these patients. And then in some of the biopsies, you'll see what we call mesangiolysis, which, is that showing up?
Yes,
perfect.
yes.
Which for me really just means that the mesangial region, both the cellular region and the matrix, is very bubbly appearing. It's beginning to lyse. It's beginning to become destroyed, if you will, by the ischemic pattern that is happening in these patients. And then finally, in some patients, you get some significant red blood cells being deposited actually in the muscle layer of the arteries or the blood vessels. So these are some of the very common appearances. And then, of course, the edema that will actually show up in the same area are also very commonly seen in the TMAs. And particularly, this happens to be a kidney biopsy, but you can see this actually in other tissues.
Fantastic.
Yes, so as the doctor explained, biopsy showed and confirmed TMA. So when she presented with all of that hemolysis ongoing, we repeated the blood work, and ANA, interestingly, came back to be elevated with a speckled pattern. And this was actually just negative 10 days ago at the outside hospital. We also ran a full scleroderma 12 antibody panel, and that came back positive for the anti-RNA polymerase III antibodies, which is suggestive of systemic sclerosis.
So at this point, we would like to invite the audience to kind of come up with the final diagnosis and explain possible pathophysiology of what happened.
You're basically asking, this was scleroderma, and why do you think it was negative and now she's positive, and what could have caused this to happen? And you're getting a prize. This is the third question. All right, gentlemen, go for it.
But I don't think you can have two prizes.
Nobody else is going to volunteer.
You can prize to a friend.
Let's hear it.
Like the prozone phenomenon could have been one explanation with really high antibody titer in the beginning, and it was negative on the blood test. And that could be resolved by diluting the sample. So that's one possibility. The other could be high tissue sequestration, resulting in like true low blood immunoglobulin autoantibodies, but actually a tissue positive phenomenon, which for that TMA, if the IF shows tissue ANA, then it might be an indirect ANA for this case. I don't know if there's a tissue anti-RNAP3 that we can see, but tissue ANAs could be a criteria for lupus nephritis.
But I guess this is awesome. We don't have tissue RNA polymerase, but our question is also like what kind of ties the diagnosis together.
There's a couple comments online. One said, "Did you think about viral infection?" And another one, "What about an intestinal biopsy?" Just wanted to bring those forward.
We did not do an intestinal biopsy.
She did have like viral panel. Everything was negative with this diarrhea.
So the steroid she got plus the positive anti-RNAP3 triggered the scleroderma renal crisis.
The steroids? Okay, he says the steroids precipitated the scleroderma. What do you guys think? What did you come up with?
That's correct. So the final diagnosis is scleroderma renal crisis precipitated by the high-dose prednisone.
Winner, winner.
What do you want, a champagne or chocolate? I agree, that was not an easy one. So Claire was saying, looks like nephrologists don't drink as much. Last time I was at the, literally I was at the ASH workup last year, we had all chocolates left and all champagne gone. I don't know what you guys are doing. All right, go ahead.
Right. So based on that information,
No, it's a
we wanted to highlight the relationship between glucocorticoids and scleroderma renal crisis. From the studies that we looked into, it was noted that about 60% of the patients who presented with scleroderma renal crisis actually have been on steroids for at least a month prior to their presentation. It was also noted that these patients were on high-dose prednisone or an equivalent. So from the studies, it was not sure if this was to be called a strong association between the two or a causation. And some of the proposed pathogenic mechanisms include, number one, exacerbation of hypertension caused by water and salt retention due to the steroids. Another mechanism is inhibition of the COX-2 pathway and also overexpression of the renal endothelin receptors. And these two together would lead to vasoconstriction of the renal arteries and arterioles, leading to ischemia in the juxtaglomeralar apparatus, leading to stimulation of the RAS system. So the question is now, what do you do next for this patient? And there's a poll. Oops.
Can you get that pointer out off, Claire? Okay, perfect. Thank you.
hold on, I need to, where is it?
Click and click on that laser pointer.
There you go.
I got it. Thank you.
Okay. ASN, of course.
Early winner.
All right.
Okay. Compliments.
So far, they're going for the basics.
Okay. So, absolutely, I think there was a question, what to do next? Oh, okay, so before the management, I mean, what should be done next? So we did genetic testing for this patient, which came back negative. She tested positive for this variant, which is identified as an intronic variant, not predicted to alter splicing. It was classified as a VUS and thought to be a benign variant.
Can I just put a comment from the virtual audience? This is from Al Kim. He's a rheumatologist, I know. He says, I'm more skeptical with the correlation with glucocorticoids. Still 40% of scleroderma renal crisis patients are not on GCC. And then he's saying, you had ground glass opacities, right, on the first? He's saying there could either be pneumonitis associated with interstitial lung disease or pulmonary hemorrhage. He would recommend checking a PFT to see if DLCO is low for ILD or high for hemorrhage.
I think she did that as an outpatient. They did the PFTs.
Yeah, I think her lung disease has improved, so the initial presentation improved after this.
It's the RNA polymerase 3 on scleroderma patient. Steroid will trigger the renal crisis, not the other patients. It's that red thing you showed up. Patient is RNA polymerase 3 positive.
RNP3
11.
You're talking about the
Epitope
ribonuclease polymer, right. So you're saying that's more associated with prednisone than any other?
Not the other. If you don't have that positive, you could use steroid.
Okay. So, yes, prednisone was discontinued on this patient. She was started on captopril, started on eculizumab as well per the protocol. She was on eculizumab for about 8 months, then it was discontinued. Her last dose was in December of 2022. So for the last 9 months, she was following closely with the nephrologist, has regular blood work done, no evidence of hemolysis, and the most recent creatinine was down to 1.2. Of note, and we will discuss this in a little bit, that her creatinine came down a little bit, 2.7, from 3 to 2.7 at the time of eculizumab was initiated. So was she just starting to get better on her own, or did she need the eculizumab or not? And we will discuss these.
Yeah, so we have kind of several questions, and we'll ask them of the audience and the panelists. So first of all, it takes, once we make a decision to start eculizumab, it takes a little bit of planning, especially if it's an outpatient. You have to get insurance approval and everything. So by then, her creatinine did start improving. However, we did make a decision to continue with the initial plan. So would everybody have done the same? And her hemolytic parameters also kind of were almost close to normal by then.
No, it's a difficult question. Of course, we don't have any evidence to show that eculizumab is efficient or necessary in those patients with secondary TMAs or even in drug-induced TMAs. Obviously, when there is TMA, there is complement activation. Is it necessary or not? I don't know. In Belgium, again, I can discuss our own experience. We don't have access to eculizumab, or not easy access to eculizumab in patients with secondary TMAs. And so we would first start with AS inhibition alone, and provided things go well, we would not add eculizumab. We would consider eculizumab only in patients with life-threatening situations or renal threatening situations, I would say. So in this case, I would not have started eculizumab, for instance.
Also, like she has an underlying autoimmune disease, so how about just starting her treatment? Like the CellCept was started as an outpatient, I probably would have pushed for treatment to be started as an inpatient. I don't know if this was the case.
I think it was all kind of started at the same time.
Okay.
Yeah.
That was okay.
Thank you. What about our panelists?
Well, I think I probably would have refrained from starting eculizumab, just given the hematologic parameters starting to improve, the renal function starting to improve. But I think there's also very little downside to starting eculizumab. Granted, the cost is certainly significant and something to be considered, but it's a relatively benign intervention.
Yeah, I think you'll see in my subsequent slides that I feel pretty much the same way. You're going to hear me say that there is a new meta-analysis out there that says that 6 patients with eculizumab alone, so that should be in theory without ACE inhibitors also, did actually do better, but we weren't able to get a hold of that because it's due to be published in December. But when you think about it, and when you review, these are meta-analysis, so this has to be based on case studies, right? So we would have seen all these case studies already. I think the really important piece here is we need to see the details of that. But in our hospital, functionally, if we don't know what's going on, we will start eculizumab. But if we knew that this patient had RNA P3 antibodies, et cetera, we knew that the Adams TS13 was normal, this patient would not have been started on eculizumab. But in that time frame, we tend to have availability. We can usually dose fairly quickly because we end up borrowing doses, if you will, from other patients. So we can dose fairly quickly, and we probably would have in this patient. But again, you'll hear us say later, we would have stopped it fairly quickly as soon as the rest of the details were present.
So in lupus patients, though, we still give immunosuppression, and sometimes lupus-induced TMA, we give eculizumab in addition. So why wouldn't we do this in this case? So just treat the underlying scleroderma, but to prevent the further renal injury, why not? It's not an immunosuppression, so why not block the complement, temporarily calm it down while you treat the overlying autoimmune
As long as we recognize that's an empiric approach, it's not evidence-based.
Yes, correct.
There is a virtual question from Dr. Samaniago. She's asking, please quote data that justifies use of MMF in this patient.
It's what we do in lupus patients.
So are there any benefit of starting or continue eculizumab from the kidney point of view? Like it will improve faster the renal function? I don't know, I'm asking the rest.
It's empiric.
It's empiric, but do we know if are there any data that will improve faster the renal function?
And again, I don't want to skip ahead too far, but I present the case where patients are being started on eculizumab and they're still going to end stage. So again, it's about it's the flip of a coin, frankly. The real issue is understanding why we're starting it. Well, we're starting it because we don't know what's going on, and because of what Dr. Weitz has said. If you've got the endothelial injury, you have risk for having complement activity, right? It would be better if we had evidence for that, but there's at least coming to be some data that would say that interference with the glycomatrix or glycocalyx in these settings of severe hypertension or drug toxicity, et cetera, maybe it does make sense to block complement.
It's for treatment of the scleroderma, though, right? The CellCept. Treat the underlying disease. We had a patient exactly like that. We initially treated with steroid, then we find the polymerase III positive, we stop it. Use CellCept and cyclophosphamide. Her soluble MAC actually is pretty high. I was trying to trigger use eculizumab, but as soon as we get up the ACE inhibitor to a super high dose, and her kidney function improved, her other things improved. We never need to dialyze her, even get her creatinine up to 5s.
Did you remeasure the soluble MAC? No.
Hi. Hi. I always fascinated about, the biopsy of TMA, and we always think about TMA as a complement method, but it's always, it could be coming from something. Like, I am wondering, is there any way, like, for example, in pathology, that we could stain something like, I don't know, like tissue SMAC or something, to see whether there is, like really a local complement activation, because there's a lot of cases that you see TMA that only happen in the kidneys, and that's not, peripherally, and, and maybe that's the case that the complement bucket is not working.
Also in the upcoming slides.
Stay tuned.
Yeah, we looked retrospectively at 10, actually 11 lupus patients who'd failed other therapies. And they all had TMA, and they really represent a subset of lupus patients. And we treated those patients. 5 or 6 out of the 10 had underlying complement mutations. Some had multiple mutations. So in that subset, it's a smaller number, but those that have actual TMA that you can document, those patients do respond to complement inhibition. And we had one patient who had 3 mutations, go figure that, 21 years old, and her rheumatologist decided to stop the ECU on her, and she lost her kidney. That's not something you want to have happen. So I think you have to think about where the patient is.
I think this is where the consortium probably can help, is how you actually read the pathology on TMA, because I think the Ranke model from Harvard, I really like it. They talk about endotheliosis versus angiopathy and presence or no presence of microthrombi. I think, at least from my experience, the ones that we see microthrombi, angiopathy, are more autoimmune diseases like scleroderma, antiphospholipid syndrome, lupus. And the ones you see drug-induced are more like preeclampsia, endotheliosis. So perhaps going in that route and defining the 2 types of pathology and renaming the disease as endotheliosis or endothelial injury versus more angiopathy and microthrombi. I think that will help us, because maybe the ones that have more endothelial injury, more endotheliosis might respond to, I don't know. That's the way to look at it, I think. We have path. Let's look at it.
I think, that makes perfect sense to try to separate what really is a TMA. Yeah. Can we, by histology, figure out what the difference between these are? It makes wonderful sense if it can be done.
Yeah, I think in this patient, the rationale behind starting the eculizumab, just like you pointed, just to hopefully preserve the kidney function and prevent further decline in such a young patient.
So, I guess looks like nobody really would have used eculizumab in this case. So the questions about risk of TMA relapse and how would you monitor this patient are kind of hanging very theoretically, but we still would like to hear what you guys think. There's also a comment in the chat
there
about...
are actually a few different comments in the chat that I'm just reading. I think one person did say that interstitial lung disease would be the leading reason for MMF use. Then would the cost and infectious risk play a role in your decision making? They always do. From a room perspective, not enough information has been presented to tell me if this patient has limited or diffuse scleroderma, makes a difference in prognosis and possible immunosuppression use. What was the presentation like, do you remember?
In terms of the scleroderma, the initial thing was the interstitial lung disease. And then later when they examined her more, they noticed like the salt and pepper rash. So it was kind of in that range.
Yeah,
okay.
She had skin changes, but nothing else.
Okay. All right. And then we went to the risk of TMA relapse.
Any thoughts about the risk of, or the renal limited versus extrarenal manifestations of TMA?
So, yeah, what did we guys go through the risk of TMA relapse question? Yes, go ahead. Shannon, sorry. What do we think is the risk of relapse in a patient with an autoimmune TMA?
I guess my comment is on a negative genetic test. I would love to know the ancestry of the patient, because patients that are non-European descent are disincentivized to have a variant. And
she was African American.
here we go, which has the most private mutation of all ancestry. Therefore, a lot of the variant may be even filtered out. So I'm not sure if a negative genetic test here, this is really what I don't know. Also for Thai patients, what I would take care of. If this is truly a negative genetic test, so that we just don't know.
Yep.
So risk of TMA relapse, what do you think? Brad, you want to take that one?
I would say with the arguably negative genetic testing, her risk is likely very low, presuming that she has ongoing treatment of her underlying disease.
Okay. And in terms of monitoring this patient?
Carefully.
That's the best answer. All right, I think we'll skip that one because I know they're covering it in their talk. All right, so we move on. Any questions for case one? Any other thoughts, questions, comments for case one? All right.
Okay, so we'll move on to case number 2. This is a 19-year-old African-American male who was diagnosed with the SLE and has a biopsy-proven lupus nephritis, class 3 and 5, that was done back in January of 2012. At that time, he presented with rash, had Raynaud's phenomenon, labs were significant for a positive ANA and nephrotic syndrome. But the kidney function for the most part was okay, creatinine ranging between 1.1 and a 1.5. He was put on MMF at that time, 2 grams a day, but at that time and throughout the years, he always had issues with medication adherence. A year later, creatinine bumped up to a 2. Although proteinuria was improving, he was switched to Cytoxan and rituximab. The thought was also just maybe to assist with his medication adherence. In 2014, kidney function continued to decline. So he was switched, because of the proteinuria was still stable, he was switched back to MMF, but at a higher dose, from 2 grams a day to 3 grams a day. Between 2016 and 2021, he had issues with the uncontrolled hypertension. He still had poor compliance with his medications. So Benlysta was added at that time, but it was not really clear if he was started on it or not. At that time, creatinine was at 2.4, UPCR still remained at 2 grams. And interestingly about him, although these complements are low, he chronically had these low numbers. So this is not something new. He had chronically low complement levels. In December of 2021, he presented to the ER complaining of fever, diarrhea, was found to be neutropenic. His absolute neutrophil count was 0. He had CMV viremia and was diagnosed with CMV enteritis as well. Creatinine bumped up to a 3. So he was treated with Valside, and the dose of mycophenolate was reduced given the viremia. January of this year, he comes in again with the same complaint, same presentation, readmitted for another episode of CMV enteritis. So MMF was held during the hospital stay and a discharge with plans to resume it as an outpatient, but unfortunately he missed his follow-up appointment.
Can I just interrupt one? A comment just came from Dr. Cynthia Nast. She's a pathologist. I think this is in reference to Kenar's question. She says we need to use computational pathology to identify novel features that may differentiate these disease processes on histology, which is an interesting and potentially fruitful area for the application.
A few months later, he comes to the ER complaining of intermittent facial swelling and saying that he just wanted to check on his kidneys. He was found to have significantly elevated blood pressure, clear evidence of MAHA, and there was concern for TMA. Creatinine at this time bumped up to a 6.6. We discussed with the patient about dialysis. He was not really interested in that. He denied any uremic symptoms, and he said he just wanted to focus on the lupus and controlling it. So he was pulsed with steroids. He was put back on MMF at a smaller dose, and given that CMV PSR was still detected, he was put on Valside. So question now, what is the etiology of the TMA?
Okay, malignant hypertension is winning. CMV is clearly losing, and scleroderma and lupus are kind of on the sidelines. Malignant hypertension.
Interesting. Right. So a month later, given the decline in the kidney function, he underwent a kidney biopsy, which showed MPGN pattern with duplication of GBM. He also had evidence of acute TMA with endothelial swelling and segmental obliteration of capillary lumen. Also showed extensive glomerular sclerosis. The IF, the sample that was sent, the glomeruli were all sclerotic, so it came back negative. However, his EM did show immune complex deposition in the subendothelial and mesangial areas. So the final diagnosis based on the kidney biopsy is MPGN with subendothelial and mesangial immune complex deposition and concurrent TMA.
So at this point, we have, again, a dilemma. Patient has kidney which doesn't look very promising from recovery from any treatment, but at the same time, the patient has TMA and has kind of extra renal manifestations, and he is actively hemolyzing. So he's had several visits, several ER visits and hospital visits with ongoing MAHA. So what would be the best treatment for this patient? So I guess before we, and also like what exactly precipitated this whole thing. So before we kind of go over what we did, I just wanted to see what the panelists would think.
And I think with that biopsy description, the horse is out of the barn. And it's probably, at least in large part, due to ongoing lupus nephritis activity that wasn't controlled for years. So this glomerulosclerosis likely was the precipitating event for a hypertensive crisis, which then could have caused this malignant hypertension kind of picture.
Yeah, I really want to bring that point up. Do you think the malignant hypertension was the cause for TMA here? Because that is what a lot of people answered, and I always question that diagnosis. I'm biased against it, so I just want to hear what you guys think.
My opinion, I believe in malignant hypertension-induced TMA, but I don't think that this patient was it. I think that there are patients that have a long-standing history of hypertension who are often non-compliant with medications. They do come in with blood pressures that are 250 over 150 and have no other systemic, if you will, findings except for obviously the retinal changes from very poor blood pressure control, et cetera. This gentleman, I think he's classic for the TMA that occurs in lupus. It occurs almost always later in their disease course. So I would have said that the lupus would have been the more likely cause of his TMA.
I just want everyone to know that Dr. Java wrote up a very interesting case that fulfilled Koch's postulates in a transplant patient. This patient was not a transplant patient, but this patient did get a drug that I abhor, MMF, that seems to do what it does. It reactivates CMV, BK, and other viruses. So we had a patient, Dr. Java was there, got CMV at an extremely low level. Biopsied it, showed an MPGN. Did we treat with eculizumab? Yeah, we treated with eculizumab initially, and then we stopped the eculizumab. We did the genetic testing. There was nothing there. And then she got CMV again. at a very low level. And again, her creatinine went from 1 to 8, all the way down to 0. And then we stopped the eculizumab. We did the genetic testing. There was nothing there. And then she got CMV again at a very low level. And again, her creatinine went from 1 to 8, all the way down to 0. And then Only this time, she had CMV, so we treated with valganciclovir. This time, I don't think we treated the second time with eculizumab. We just treated the CMV, and it went away. So I think this is what's going on here in this patient, and I think the MMF is the culprit. The problem is, how do you treat the lupus? And that's a problem.
I don't know if it was mentioned and I missed it. What about antiphospholipid antibodies? Were they tested here? Because fulminant antiphospholipid syndrome will look exactly like scleroderma renal crisis. And that's the situation where you may use plasmapheresis.
That was negative.
No, I completely agree with the transplant approach. I mean, this is CMV to me causing the TMA rather than the lupus. I think you're overly immunosuppressing this patient. Like you said, it's already out. There's no need to treat the lupus nephritis component. It's all chronic. I would treat the CMV more aggressively.
I mean, it's taking the biopsy for CMV.
Interesting.
So that was in the differential, CMV versus lupus.
Right.
It's 50-50. All right.
Okay, so a few weeks later, he presents again to the ER with the same high blood pressure, this time with volume overload, ongoing hemolysis, serum creatinine up to an 8. As Dr. Vinikova mentioned, he was started on eculizumab because of the ongoing hemolysis, not for the kidney function. Genetic testing came back negative. His C5b9 was elevated. Any thoughts?
Yeah.
You have such a high activation of the MAC complex. Can you blame this on hypertension?
Who's going to take the bait?
I mean, can you really get hypertension to trigger your complement to that level to actually cause endothelial injury is my question. I think it's the other way around, where it's endothelial injury coming first, causing hypertension. So because that doesn't make any sense to me, unless someone can explain how hypertension can activate complement.
Panelists have any comments on this?
No.
I think endothelial injury is the mediator.
Yeah.
All right, go for it. Question. Yes.
I will also say we don't know what MAC is usually doing in a lupus patient either, so we need to keep in mind that there's a lot of this baseline data we just don't know.
So for the malignant hypertension, what if you have a severe shear stress and then causing endothelial injury from that, and you activate, because there are like a substance that can activate the complement at the endothelial. Yeah, I think that could be a pathophysiology, but I don't know how much it can contribute to the 1,000. And for the SMAC elevated at this level, could it be because we don't know, SMAC is a common pathway. It could be, classical pathway with the lupus, with the infection, with all that, with alternative. But yeah, so there's a lot of things that could activate complement in this patient.
Question. On the kidney biopsy, the most recent kidney biopsy, did they stain for C5b9 or C4b? C4D. Yeah. Because that's what you usually see with lupus. So, and that would be really worth going back and asking them to do that. So
no, it's just we didn't have very much tissue, and there was so much global sclerosis that they did very limited.
Just a thought. The other thing is that it also points out to you that the problem with continuing long-term immunosuppression in patients. I mean, recurrent CMV and all these other infectious complications are really an issue. And one of the things that you don't see with complement inhibition, terminal complement inhibition, the only thing you see is meningococcal infection, which you can prevent. So you have to kind of keep it in perspective. Even in the C3 pegcetacoplan trials, we had very few infections, but everybody's vaccinated and they're on prophylaxis and all of that. But, antibacterial and fungal infections, we didn't see those. Whereas with lupus, long-term steroids and all of that, you see a lot of fungal infections. One of our patients died of that. Long-term steroid use.
To remind you that he was very non-compliant with his medications. He would take that
He
prednisone
wasn't on
like,
anything.
yeah, PRN, just whenever he has symptoms, he will take it, then stop it, so.
Yeah. And why was that?
That
Did it
was
make
just
a-
him, yeah.
I mean, we need to
Yeah.
ask our patients that
Right.
question.
Yeah,
because
yeah.
Sure.
It made him feel bad, so maybe he should be substituted.
No, I mean, he's a young patient, and he, you know, he had a life, he had a job, and he always, like, it's not like he didn't want to take anything. He would rationalize that, okay, I don't need this now, or now this is from lupus, I'll take this, or this must be CMV, I'm going to take this medicine. So it was constantly like that.
Yes, in line with this, adherence is really key in patients with lupus nephritis, and we have observed also some cases with such evolution. Two questions. First, was the CMV resistant to valganciclovir, which is not that uncommon actually? So
It was not.
It was not. So.
Yeah, it would clear.
Uh-huh.
So between all of these things, it would clear.
Okay.
Initially, but then it would happen, and then
Yeah.
it would clear again.
Because I agree with the hypothesis that CMV might be a driver of TMA in this patient. And second question, more generally, what do you think about the biomarkers for complement activation? Personally, we don't have, to my knowledge, strong evidence to support the discriminative effect or use of those biomarkers of complement activation in the literature. So I'm always very careful in interpreting the C3b or C3, even the MAC, the serum MAX. So I don't personally base any therapeutic decision on those biomarkers. We know from the complement experts that these assays are very also, how to say it, technically complex, difficult, and so it's maybe a comment on this.
Thank you. Just a few comments. Firstly, with SMAC, it rolls off the tongue very easily, but if you ever go to a complement meeting, don't say SMAC, it's soluble C5, you know. The second thing is there was a comment that we can get elevated levels of soluble C5b9 from the classical pathway. And all of you need to understand that when we activate the classical or the lectin pathway, after they are activated, 80 to 90% of all the activity goes through the alternative pathway. So when you see excuse me, I catch my breath. When you see a high soluble C5b9, it's from alternative pathway activity. And then referencing secondary TMAs versus complement-mediated TMAs, is there a unique biomarker signature to identify one from the other? And the answer is no. As far as I can see from our studies, they all have a signature when complement is active of active complement, which could be low C3, low factor B, high C3C, high BB, high soluble C5b9, low C5. And what you'll notice if you look at different reports on, for example, soluble C5b9 that are done in different labs, the prognostic significance of an elevated C5b9 is often laboratory dependent, and that's because the tests are difficult. For example, in our lab, when we receive a plasma or a serum sample from a clinician, we aliquot it out and it's stored in the -80. When we use a sample to do testing, it never goes back in the -80. It's a one use only. And if you use it and then refreeze it, then use it, then refreeze it, the activity changes. And then there's some other assays that we haven't even talked about, which are cell-based assays, and those are really, really difficult to do. And some of these assays are really homegrown assays, so different labs each have their own unique protocols and SOPs for doing the assays. And so a lot of this needs to be standardized. But I think what really strikes me as I listen to these talks is that differentiating secondary TMAs from complement-mediated TMAs is possible, but it's possible based on, for example, with HELP syndrome, getting other tests that are ancillary to, that are associated with the secondary disease process, or the process that's driving the secondary TMAs. And so it requires a really astute differential diagnosis and then getting the appropriate tests.
I'm wondering about the genetic test that was done, because he's a male, young, with a negative C1q. Whether is this the classic lupus that we know, or that he has like underlying complement deficiency, or maybe other gene tests like APOL1. People try to associate APOL1 with TMA. I don't know much about that, but perhaps if the genetic test is just complement, we might be missing other things.
He was negative for APOL1.
But this genetic testing was referring to the complement testing.
Mm-hmm. Yes.
Which usually, I'm not sure if complement deficiency was going to be covered well from the usual nephrologic-based panel. Yeah, which when they are in deficiency of those things, they are predisposed to autoimmunity.
Right. Yeah.
Yeah, no, I think you're right. I think there are those subset of patients that are C2 deficient, or you're looking for C1q, with which the genetic testing will not cover. But I think this is just the standard complement testing that the patient underwent.
Okay, just then, oh, sorry. Sure, there's a question.
I just want to add, I think the answer is in his first kidney biopsy. When you have sufficient material to do the staining, the second kidney biopsy, it was insufficient material for the immunofluorescence. So you should go back to see whether there is a deficiency in your first kidney biopsy, I think, or just measure it in the circulation.
So even though it was like 10 years ago?
There was C1q, there won't be a deficiency.
All right. Any questions?
Yes, go ahead. No, I think we're good.
Okay. So, and then July of this year, he came back with chest pain. At this time, MAHA was resolved. He was still on the eculizumab. Serum creatinine worsened. And given the diagnosis of uremic pericarditis, he was started on hemodialysis. Most recently, in September, he continues to have no renal recovery. He remains on hemodialysis. But because he's been without hemolysis for a few months, a decision was made and eculizumab was discontinued.
All right. So
All right.
you want to just put up all the questions, Marwa?
Yes.
We might have our panelists give us, I think they're covering a lot of this in their talk.
Yeah, so again, to just kind of reiterate that eculizumab was used because we just could not stop the hemolysis, but the duration of treatment, of course, was maybe not appropriate. So here's a list of questions for the audience and then for our panel.
We can bring these up. I think there's a lot that Dr. Dixon and Dr. Nester are covering.
Great. Well, the charge for us as the panelists was to describe how we would approach these cases, and I think you've already heard similar approaches with cancer-associated TMA and pregnancy-associated TMA. So I'll give you some summary thoughts about TMA and autoimmune disease. And remember that TMA is really just the final common pathway of anything causing endothelial cell injury. We know that from earlier speakers and earlier presentations. And specifically in autoimmune disease, we can see endothelial cell injury from one or more of these injury mechanisms, including direct endothelial cell injury, activation, accentuated activation of the coagulation system, of the complement system, or inflammation in the microvasculature. And what poses a particular challenge in autoimmune disease is that similar to, I think, what was described earlier with transplant-associated TMA, that there can be other clinical features that are due to the autoimmune disease itself that may obscure the diagnosis of TMA, including autoimmune cytopenias, renal involvement of the autoimmune disease itself, extrarenal manifestations of the autoimmune disease. And then this is further compounded by the nomenclature in the literature being very unclear, with interchangeability of terms of TTP, TMA, HUS, that has ultimately led to difficulty quantifying the incidence of TMA in these diseases. And that ultimately leads to downstream effects on our ability to detect TMA with the specificity and sensitivity of laboratory testing. So I think it's important to remember that although I'm a pediatric nephrologist and a complement-centric individual, not all TMA and autoimmune disease is AHUS. So there are certainly secondary forms of TMA that can be seen in a variety of autoimmune diseases, two of which we have discussed this afternoon, as well as malignancy, infection, et cetera. Autoimmune diseases can each have their own inherent forms of TMA. You can see TMA in lupus nephritis, as we're describing here, scleroderma renal crisis, CAPS, TTP in lupus. As we pointed out, the secondary forms of TMA may respond to targeted treatment of the underlying disease process. So whether complement-targeted therapies have a role in these secondary TMAs remains questionable, because there may be therapies started at the same time. But not all TMA that happens in autoimmune disease is not AHUS either, or complement-mediated TMA. And we know this, that many of the autoimmune diseases are characterized by complement activation, and in the susceptible individual, that complement activation can lead to dysregulated activation and ultimately endothelial cell injury. And so if we see a persistence of the TMA disease process despite adequate, what would be adequate, or considered adequate or aggressive therapy of the underlying autoimmune disease, we should at least have our antennae up for this being a complement-mediated TMA. And so even if a secondary form of TMA isn't AHUS, there's still, I think, anecdotal evidence in the literature and growing evidence in the literature that complement-targeted therapies may still have benefit, and this is true for lupus. There are case reports and then subsequent meta-analyses compiling those case reports where proliferative nephritis with TMA, as well as nephritis without TMA, have had benefit in some refractory cases. And there's very recent literature to support the use of eculizumab in refractory cases of CAPS and scleroderma renal crisis. And I would be remiss if I didn't at least point out that TTP is important, like we talked about in pregnancy-associated TMA earlier. TTP is vitally important not to forget in autoimmune diseases, in that it can be associated with autoimmunity in both adult and pediatric patients, and with the high mortality that is associated with it, we have to at least keep that high on our differential and react accordingly. I'll turn it over to Dr. Nester.
Yeah, that's good. So I will actually first show you that I do have a number of disclosures because I work a lot actually in the complement inhibitor field, and so that's necessary, and I think that that's available to you whenever you would like it. And it's probably good that I'm at the tail end of this conference because I want to throw out what might be a few devil's advocate statements here, if you will, because this is the dilemma that we face when we're dealing with thrombotic microangiopathies. First of all, there are no randomized controlled trials for the vast majority of what all of you have had to say today, and trial design specifically have eliminated these groups of patients. So we haven't gotten that evidence that we might need. Then, and you all know this, but I'm just going to state it because it got me into trouble when I was actually reviewing for this particular session, that case reports, retrospective studies, et cetera, that's not as good as evidence. It's just not because of how those patients were being treated. There's not only the issue of negative reporting bias, but that's that everybody did something a little bit different that makes it hard for me to generalize when I'm talking to you about what was successful or what wasn't successful. Then there's this issue of abnormal complement biomarkers, something that Richard and I face on a daily basis in another complement-mediated disease called C3G. Abnormal complement biomarkers does not constitute evidence of mechanism of disease for any of the TMAs or any of the diseases that we've talked about. And I'm going to focus a little bit on that because I think my last slide is our call to action, if you will. How are we going to fix this, so that we can be better at I don't have the answers, don't get me wrong. It's more of a call to action more than I can tell you what we're going to do. The reason complement biomarkers, you have to be very careful with them because they represent your activity of your innate immune system. We all have one. It's very active lots of times in our lives. You cannot necessarily say that innate immune activity is disease causing, and that's really the main point that I wanted to make there. Defining when they are disease causing requires a lot more science that frankly we just don't have. Putting all of that aside, of course, we have a wonderful agent that may do a lot, agents, I should say, so complement inhibition may actually be very, sort of clinically beneficial for our patients. But of course, as we all have talked about already, that still is experimental. It is still very important that we think about it empiric because then that means we have to be ready to take the next step. And then the next thing is that this came up with some of you, and so I just wanted to give you an example about, and I chose C5b through 9 because I thought that was going to be one of the biomarkers that you all would want to talk about. And why look at a biopsy instead of looking at the blood? This was brought up earlier. The reason to look at the biopsy potentially is because of something Richard said earlier. The C5b through 9 is formed in vitro. So you have to be very particular about the specimen that you're dealing with in order to be able to trust that greater than 1,000, for instance, we saw earlier. Then there's the issue of it's a very short half-life complex. So you'd also need to be thinking about that. You could get a low number and it's not the right number for your patient. So keeping that in mind. And so now I'm just going to share with you the biopsy question, why people might go to the biopsy, but why it's also not good. And I recognize this is very tiny, so I'm just going to show you. Top right there is, for me, right, left for you, I guess, is healthy kidneys. And then across the bottom is what compartment of the kidney was there C5b through 9 in healthy kidneys. Mesangial is there, you'll see capillaries are there, you'll see the vasculature is there. Really the point for me to be talking to you about this is that C5b through 9 is present in normal kidneys. Of course, it's part of your innate immune system. The Columbia group reported this at one point. You might recall when they used eculizumab, again, for that other disease, C3G, they saw that as their comparator group, they were seeing just as much C5b through 9 as they were seeing in a number of their C3G patients, which is clearly complement mediated. So the point is that we're not ready for prime time yet on some of these biomarkers. You can find multiple examples of this, and I can be a little bit tongue-in-cheek that the reason this patient had a C3 deficiency because he had active lupus. So the C3 deficiency was acquired. It was because of presumably very active classical pathway activity in a lupus patient who has all those extra antibodies triggering the classical pathway. And again, I'm being a little bit tongue-in-cheek, but the point is that the detail of why that C3 deficiency is there is incredibly important. And as pediatric nephrologists, we know C3 deficiencies occur in children, acquired C3 deficiencies occur in children all the time, and then they get over it. And that's really a problem, I think, if you're relying on, I think, another thing that Richard said just a few moments ago is that it's not really the complement biomarkers that are helping you guys as much as it's those added to what else the patient has going on, whether that's abnormal LFTs, AST, and ALT, or whether that is skin disease that's really bad, so you really know you're dealing with a lupus patient. So again, it becomes somewhat important to be able to combine both of those, or to certainly make that our biomarkers are more useful to you. So then I thought I would just very quickly share with you my concept of scleroderma renal crisis, because you're going to see that I vary a little bit from some of you, and also vary in what I think about lupus patients, frankly. So I wanted to give you my sort of concept of what this disease is, because I also want to be able to, that for me informs why I would treat a scleroderma renal crisis in a very particular way. And for me, it's this issue of chicken or egg, and it's already been brought up a little bit here, but is it the, what came first, the endothelial injury and then the TMA, or the TMA and then the endothelial injury? What exactly is coming first in this particular group of patients? I agree with what has been said in this room. We don't exactly know what the etiology of a scleroderma renal crisis is, but I am very comfortable with the basic science data that suggests that it's this idea of juxtaglomerular apparatus hyperplasia and very high renin secretion, hence why you all chose ACE inhibition before you went into treating these patients. So these patients do have a form of malignant hypertension, which I'll put in quotation marks because we don't want to package them as that way, but I'm very comfortable with that concept as to how the endothelium would get injured in this group of patients. And then, of course, we've already talked about the histopathologic changes. So I wanted, so there are no cartoons I can use in scleroderma renal crisis. So I wanted to bring this one forward for sepsis because I want to talk a little bit about what happens when you injure the endothelium. And one of the ways it's injured is you disrupt the glycomatrix. And I don't know if you can see in the top picture, you can see this very nice glycomatrix with a proper fluid layer. Then if you look at the second picture, look how disarrayed it is. And particularly, that with the disruption of that glycomatrix, it's entirely possible that, and I drew in those little H's there, that for me stands for complement factor H. It's entirely possible that if you disrupt that glycomatrix, you now also don't have local complement control. That I'm borrowing a little bit from a publication out of Toronto that talked about calcineurin inhibitors doing exactly this, but it seems very reasonable that shear stress, that attack on the endothelium could absolutely be causing this. Again, I don't know that this is true, but I'm borrowing this cartoon to make the point that we don't know, but these are the things that could actually be happening in this group of patients. So is the terminal pathway of complement activity a treatment target in this group? I'm not clear, and so I want to bring up this idea of malignant hypertension, and for time, I presented one, and I've given the references here and happy to share with anyone, but this were 19 patients with malignant hypertension, and you can see they don't tend to have as high of LDHs, they don't tend to have as low platelets, et cetera, but really the most important thing that I sort of poked out a little bit earlier today was if you treat the blood pressure in these patients, they get better. And that's really the point. It's not that we needed to use eculizumab in this group of patients. It might have been augmentative. I'm not arguing that point. But the point really is that you don't necessarily have complement-induced disease if you have endothelial injury that actually might be developed for the different mechanisms, if you will. So, and I only bring this up just so that I can share with you. I am leaning a little bit towards this concept of very high renin, very high, well, I'll just say that, more malignant hypertension induced in these scleroderma renal crisis patients, so that when when I look at this particular information, so 7, and again, I mentioned to you earlier, I was having a little bit of trouble finding cases of sclerodermal renal crisis that were treated with eculizumab, so I wanted to be able to share with you what I could find. 711 SRC TMA patients required renal replacement therapy. 4 of those 7 were treated with eculizumab. So again, we're not talking about a very impressive improvement, but again, retrospective data. This is not as useful to us as we would like it to be. But also, take a look at the figure there that came directly from their manuscript. You can see that whether you were on eculizumab or no eculizumab, again, it was pretty iffy if you were going to even get a hematologic improvement in this group of patients. So the platelet may have gone up or it might not have gone up. And I hearken back to, this is not unlike, remember when we were treating all of our atypical HUS patients with plasma exchange, they got hematologic remission many times. They didn't get renal remission always, or remission is not the right word, but renal recovery, I would say. So again, it's sometimes hard to connect hematologic changes with the renal changes is really the point that I wanted to offer. The problem is deciding what is unique about those SRC patients that don't go to end-stage kidney disease. Right now, at least, it doesn't seem to be that it's eculizumab treatment that has prevented that. But I'm not sure that it's not complement-mediated in some fashion, and maybe they didn't start early enough, et cetera, et cetera. So just keep that in mind. There is a meta-analysis that both Dr. Dixon and I really wanted before we talked to this group, and I mentioned it to you because it's going to be published in December but basically 14 of 17 patients got a hematologic improvement, 6 who received eculizumab alone. So it would be nice for us to see those 6 patients, right? We want to see what was it about terminal complement blockade that actually made them improve, if you will, and we also need to obviously see what happened to their kidney function. And guys, I know I'm going very quickly, but so I will just sort of undo all of this and say, and that should say at the very top, my approach in SRC, and this is again opinion-based, but I agree with what everyone has said in the room that controlling the underlying autoimmunity is key. And in this particular patient, if you believe the data on RNA P, you should be stopping the steroids. And I know for nephrologists, sometimes that's hard on us to stop steroids. But in general, if you believe that data, you should stop the steroids in her. Then, of course, you have to, it's not just ACE inhibition, but it's also very good blood pressure control in these patients. We need to give the endothelium some relief. And then I always throw in here, because I think that we can sometimes get aggressive with our diuresis and aggressive with our ultrafiltration. So we need to try to be gentle on these patients so they don't have the microvascular damage that can come from overdoing some things. And then I already sort of gave you the prelude for this, but in our hospital, before this would have all been sorted out, terminal complement blockade would have been added, frankly. But as soon as we were clear that it was SRC that we were dealing with, we would have backed off. So our patients are very unlikely to get more than a couple doses, maybe 4 doses at the most, meaning they won't even get fully through induction before we're actually stopping. And then I thought, and no one actually asked me, but I thought I would mention that I don't generally do genetic studies in an SRC group, because I go back to this idea, I'm perfectly comfortable giving one disease, one setting for this, but it wouldn't be wrong that you would do it. It's just that this is not a direction that I would classically go. And then similarly, if this patient, which a lot of SRC patients do, go to transplant, we don't use prophylactic terminal complement blockade at this point. And again, it would be wonderful to have an opportunity to say use 4 doses or something like that, but this is not something that we have chosen to do. But again, I can count on one hand the number of cases that we've actually had to deal with. So. Now I'm going to move very quickly into the lupus patient, because you're going to see I'm being a little bit schizophrenic on this. I'm flipping over what my approach would be a little bit. But I think that People in the room are right because, you know, Richard and I have always called it the TMA peacock. You know, viruses are definitely on that list of things that actually cause very good TMAs. I think it's entirely possible that the CMV has caused this young man's TMA. But in the absence of CMV, I see a lot of lupus-related TMA, so I'm perfectly comfortable calling this lupus-related. So, but again, I don't know which one it actually is. I think that because it's probably found in about 10% of lupus biopsies, some form of it, whether it be the mesangial or fibrin deposition, or even this concept of duplicated membranes, because the pathologist thinks that there's a chronic TMA present. And 75% of them will do what this young man did, where they have all of the lupus stuff first. So it tends to be that it's moderately clear to you that this is a lupus patient, and then they develop the TMA. It's rarely, or it's not as common, that the TMA comes first. So I think that I'm also comfortable with that concept. But as has also been said earlier, I think that I'm also, again, comfortable saying that this is lupus if they meet the criteria for lupus. Even if I see it on their biopsy, you know, or if I have just a clinical hemolytic process, I'm provided it's, you know, direct Coombs negative, et cetera. But I'm completely comfortable calling that clinically. The problem I think we face in lupus is the same as we face in a lot of these areas, and I see this kind of thing happening, is where we say deficiencies in components of complement cascade can lead to monogenic lupus. I think we all can agree on that. There are animal models, there are human models, there are models that we can really depend on to hang our hat on this. But this is a place that, again, I get into a lot of trouble because I read lots of biopsies and I do lots of complement testing. So low levels of C3 and C4 are present in the clinical setting. That is not what I would call good evidence that complement is driving this disease. That is, complement is associated with this disease. Similarly, glomerular deposition of complement is almost universally seen histologically, obviously, in lupus patients, but that's not the same thing. Harken back to my C5b9 picture, if you will. That's not the same thing as saying that complement is driving the process. And again, I'm not professing to know the answer to this, but I bristle just a little bit when we think about those last two, because that's not, to me, clear evidence that complement is driving the process. So I drew up another cartoon. Again, I don't have a great cartoon for lupus, but I chose COVID because we'll all be very comfortable with COVID. So the concept really I wanted to point out here is that absolutely, as has been stated, I think, by Dr. Weitz and others in the room, that you can get a complement activity at the level of the endothelium. It can definitely be classical pathway. As Richard has already commented on, all pathways shuttle through the AP, so regardless if it is classical pathway at the level of the endothelium, you are going to get yourself all the way down to MAC. So this absolutely could be happening in lupus. I don't know for sure that it is, but it could be. So what I wanted to just share with you is this relatively largish study, because this is why I'm flipping about whether I would use eculizumab, not use eculizumab in this kind of autoimmunity. 222 patients, and they're separated into 4 categories, just so that you can see. And I know this is going to be a very busy slide, but I wanted to, and this is only a portion of it. The manuscript actually is very nice. They're going to be active nephritis, they're going to be nephritis in remission, they're going to be without renal involvement at all, and then they're going to be healthy controls. And so I've just chosen a few of the biomarkers to share with you. And the first one, of course, was C1q, because we're all pretty comfortable with the activity of C1q in lupus. And you can see that C1q is low in the active lupus nephritis groups. This is, by the way, peripheral blood specimens. This is not on a biopsy. And I'll throw in my cartoon for the pathway, just in case you don't recall where these various biomarkers are. But so next I'm going to go to C3. And again, you'll notice that it is statistically significant for this group that C3 is lower in lupus nephritis. Also, one of the biomarkers that Richard brought up earlier, and is very important to us, to suggest to us that we've got really complement hyperactivity going on, and that's BB. If you've got an excess of BB floating around, and again, that's you'll notice that it's right at the level of the amplification loop, that would normally suggest to us a very active complement system. And then finally, let's go for the MAC. In the active lupus nephritis patients, you also have more soluble C5b through 9. So again, I'm suggesting to you that this is a fairly decent-sized group of patients that, yes, they're sharing with this, that these biomarkers compared to very good comparator groups are abnormal. So I'm feeling a little bit better about this data, even though it's not mechanistic data, I guess is where I'm going with that. And then finally, the pièce de résistance in this for me is that if you're really high BB levels, it actually relates to renal mortality, or renal survival. So I think that, again, this feels to me like excess complement activity in this group of patients could be a very bad thing. And so I am leaning more towards wanting to do something with these lupus patients. And again, this is not talking about TMA, this is just talking about lupus patients. One more slide on that particularly, and these were patients that in lupus that were actually treated with eculizumab. And on the left side from the seminars in arthritis, you can see that in general, you did get improvement in the hematologic parameters. The platelet trended up very nicely in most patients. Some of them it was kind of flat, but again, we accept that there may be some variance across patients. But also, if you look on the right-hand side, there was also clear that a number of the patients, even in another manuscript, so a year later, were also being reported to have an improvement in their platelet count, an improvement in their response to eculizumab, even though we would still call this a secondary TMA or potentially not primary complement-mediated disease. So here is my response, and again, this is for my lupus patients, not my SRC patients, but here's my response that's just a little bit different. So again, controlling the underlying autoimmunity is key. Same thing, good blood pressure control. Again, I'm a nephrologist, so I think that that's important. Same thing about not overdoing it if they need to be dialyzed or diuresed, which many of these patients do. If allowed locally, and I need to give you a caveat because my hospital has just made a big change on me on this, if allowed locally and the Adams TS13 is greater than 10, we will begin terminal complement blockade in a lupus patient with a TMA. And it doesn't have to be biopsy proven. It could be clinical as long as we're not believing it's autoimmune. But frankly, it's most often biopsy proven. But we will begin terminal complement blockade in that setting. And we will use it acutely. And that very frequently can be until we see either the disease is beginning to come under control or the creatinine has natered, for instance. But similar to the story for SRC, if they develop end-stage kidney disease, we assume it was the very active lupus that was really driving all of this. So we don't take them into transplant with prophylactic eculizumab, for instance. And frankly, I usually don't even genetic test these. Now, it's not, again, it's not wrong to do it. It's just that I'm very comfortable accepting the one diagnosis as being the driver in this setting. So. And then I'll just very quickly bring up the reason we've developed this sort of approach, and the reason it might change is because our hospital has just recently moved to, if I am not willing to write in the chart that atypical HUS is the cause of this patient's disease, I will not get permission for eculizumab. And morally, I struggle a lot with that because I'm not convinced always that it is atypical HUS, but I subscribe to what a lot of you have said, that it may very well be useful to block terminal complement blockade, but that to me is a separate issue than me calling this patient atypical HUS. So my hospital has made this decision that I might have to be dealing with here fairly soon. One hasn't come up, and this was just in the last 60 days, so one hasn't come up, so I don't know exactly what's going to happen. Sorry. So this is my call to action, is this concept of understanding the role of complement in the specific diseases. And you know, I recognize that I presented you a biomarker paper. Even if it was 222 patients, it was a biomarker paper. It was not mechanistic. Dr. White's presented some very nice data about C5b through 9 in cancer, in the cancer setting. That's the kind of data we need, where we really understand what is the mechanism involved. Again, we can admit that we can do a lot of other things empirically, but that's the data that we might need to actually be a little bit more formal about what we're doing. And then in the absence of that, and this is something that perhaps this group can do, is this concept of trying to protocolize what we're doing, so that even if you don't have a clinical trial, we all agree that we're only going to do 4 doses, or we're all going to do ACE inhibitor for 3 days before we do this, or if there's any way we could either protocolize or register what you're doing in the absence of doing a clinical trial, that would be fantastic. And then finally, the thing that we all want to hear about is exactly what is happening with complement at the level of the endothelium. I really like the calcineurin inhibitor paper out of Toronto. I hope that it gets reproduced in other settings and with other drugs, because I think it's a really cool idea about why these drugs might be causing TMA in our post-transplant patients. Thank you. And I know I talk really fast, so I'm happy to take questions as you guys go along.
That's awesome. I just still want to add one point about malignant hypertension, because I'm so stickler. I think there are 2 things you mentioned, Dr. Nester, that are critical. One is that if you treat the patient and the patient gets better, I think that's important. And the fact you showed that almost more than 50% of those patients got off dialysis. I have trouble when we say malignant hypertension is the cause of end-stage kidney disease, and we end up labeling hypertensive nephrosclerosis as the etiology. And I say that because in a lot of our transplant patients who come with that diagnosis, we have identified genetic mutations. So I think hypertension may be activating complement, but if it gets better, that's one thing, but I just struggle accepting it as the sole cause of kidney failure by itself. All right, any questions, thoughts, anything? Yes, go ahead, Steve.
Yeah, I was just, it's interesting, it's chicken and the egg. It could be just a deleterious feedback cycle. However you enter the cycle, it could obviously feed on itself. But I think it was very interesting that you give 4 doses, and then if it becomes scleroderma and the information comes back, it stops. You very well could have done very good things for that patient with those 4, because while you're waiting for the autoimmune disease to come under control, regardless, you still have this overactive or dysregulated alternative complement pathway, and you're blocking that, and that could be providing tissue protection in that month time frame or 2-week time frame that where you're bringing the disease under control, whether it be lupus or scleroderma or whatnot. So I think your idea of a registry is amazing, because it gives the opportunity to maybe uncover whether that is a benefit, even if it's for a short period of time.
Thank you. I think we'll have to wrap up here. As much as I'd love to keep this going, we have to free up our AV folks here. So I really, really want to thank everybody for being here today. I know several of you just came out specifically for this meeting. ASN doesn't start, even pre-ASN doesn't start until tomorrow. So really thanks. I want to thank the speakers for bringing up the most instructive cases, our panelists for putting together some insightful presentations to summarize them. I do want to thank Alexion for supporting this. It was, we really thank you and appreciate your collaboration. I do want to put in a plug that we will probably be having this meeting again next year, so we will be sending a survey out. We'd like to hear what you liked, what you didn't like, what we could do format-wise, do anything differently. So please fill that survey out, and we'll hopefully see you guys again next year. Thank you very much.